So in our next session here, we're going to move into talking more about some of the actual issues with some of the new products that are out there for patients, including drugs. And in this session, entitled Unbundling with Purpose, Designing a More Patient-Centered Payment System That Reflects Patient Priorities, we're going to be joined by Dr. Ankur Shah, who's the Assistant Professor of Medicine, an Associate Program Director for Research, and the Medical Director for Peritoneal Dialysis at the Division of Kidney Disease and Hypertension at the Warren Alpert Medical School of Brown University. We'll then also have Mrs. Elizabeth Hurlburt, who serves as the Chief Clinical Strategy and Operations Officer for Core Medics. And then joining us virtually will be Dr. Laura Williams, who serves as the Chief Patient Officer at Ardelex. So Dr. Shah, why don't we go ahead and get going on this, because I think your insights are rather telling about the bundled payment system.
Absolutely. So first of all, thank you for having me here. It's really exciting to be able to share my insights to this group, and I feel like I've already learned a lot from the prior speakers and looking forward to the next speakers as well. And I want to start by talking about a problem. So I wear a lot of hats. I am a clinician, I'm an educator, I'm a researcher, and through all of those hats, I think what I've found is that there's one kind of common thread of issues going through kidney failure treatment. And I'll start with myself as an educator. I started practicing in 2018, and I did a lecture for our new fellows on fundamentals of dialysis. I've done that lecture every year. I'm doing it again next week. And for the first 6 years, I didn't have to update my slides. Where is our innovation? Where is our progress? But excitingly, I actually get to update my slides next week because I get to talk about hemodiafiltration. And so one of the things that I recognized was that I'm not seeing progress in my field, but I am seeing progress in other areas of kidney disease. Dr. Watnick talked a little bit about progress in chronic kidney disease treatments. We've seen a lot of new therapeutics for things like IgA nephropathy, for people with diabetic kidney disease. And while I would love to be made irrelevant as a dialysis researcher, there is a bit of an irony of going into a field that you hope is made to disappear one day. And I would love to one day have to recreate myself. We're not there yet. And I have patients right now who need help right now. I personally care for about 50 people on dialysis right now. And I would love to not have anybody on dialysis. But those 50 people need help. They need things to change. They need things to change now. And as a clinician, I do note that we do have new medications that hit the market, but I don't have access to getting them into my patients. I look at new medications for itch. I look at new medications for phosphorus. I look at new medications to help prevent infections. And then I look as a researcher and I look at the United States renal data system. And what I see is they're on the market, but they're not in patients. They're not getting there. And so that goes back to myself as an educator. I can tell people that there is innovation, but I can't tell them that you're actually getting this into your patients. So we have an innovation to execution gap. And then also as a researcher, I look back to that United States renal data system. I look at the dialysis outcomes practice pattern studies, and I notice something. If you look at patterns in mortality in people with kidney failure, particularly those on dialysis, around 2011 to 2013, you start to see a change. This was chronically getting better for years and years and years, and since 2013, it really started to plateau. And so that had me wonder, well, what happened around that time period? And I discovered it all comes together. Unsurprisingly, one of the nice things about wearing a lot of hats is when they all come together, but it comes together to the bundle. And I think that the bundle has really stifled both innovation and implementation. And so as I look to the bundle, I do want to highlight, though, there were good things about the bundle. So the bundle, in my mind, is allowing me to practice 2011 medicine at the best way possible. And the bundle was implemented in 2008. It was proposed in 2008, I think it was passed in 2008, sorry, implemented in 2011. And if you look at what happened with the bundle the first couple of years, you do see things like an increase in home dialysis. You see reductions in erythropoietin stimulating agent use in patients who maybe would not benefit from them without reductions in patients who would benefit from them. You see costs go down, and you do see that mortality curve continue to improve for the first couple of years of the bundle. So I think the bundle really helps us practice the best of 2011 medicine. But I was not even in medical school in 2011. So I don't know that I want to be practicing the best of 2011 medicine. I want to be practicing the best of 2025 medicine. And I think that the bundle it's given and it's taken away. And so the reason that I'm here is I think that we need we need change because my 50 people on dialysis who I take care of every week and the hundreds of thousands who I see in data sets all need change, and they need it now. That's my perspective.
Thank you very much. And let me follow up with 1 second, Doc, and ask you this. So on Capitol Hill right now, we have nearly an entire generation of congressional staffers who are working very diligently to represent the concerns of kidney patients in their districts for their elected members. And the bundled payment system, as you indicated, dates back prior to their time on Capitol Hill and prior to their time in school in many cases. And so, in the simplest way possible, can you talk about an analogy that people would understand? For example, if you had a $100 bill and you had to pay for everything with it, what does it look like in practical terms to have a bundled payment system for all kidney care? What happens if an innovation comes along? What is the dynamic that is created if a provider is only getting the $100 bill for everything? What is the dynamic that happens on that payment?
That's a great question. And I think the way that I would describe that is if you have a $100 bill to pay for dialysis, and then next year somebody says, we have a $10 therapy that is going to make your life better, if you still only have that $100 bill, paying for dialysis is kind of like being on a fixed income. It's the same thing of when I tell my patients who are elderly on a fixed income, I have novel therapeutics to offer you. They have to figure out what subtracts to add that novel therapeutic. And dialysis is the same way. Either we have to find something to subtract to add something new in, or we have to say, I don't have anything to subtract. I have patients who say, I have things I can subtract to add something new in. I also have patients who tell me, I can't trade food for this. And so it's being on dialysis and paying for dialysis is like being on a fixed income, would be the analogy that I would share.
Okay, thank you
And it's
very
a rough way to live.
No, I think it's an illustrative example for people to understand what's happening in the kidney space and has been happening for a long time. Let me go ahead and move over to Dr. Williams. And Dr. Williams, I know you can talk about things that are very real world and examples that are coming from patients that you interact with regularly. As many folks know, on January 1st of this year, CMS implemented a major change by folding oral-only medications, such as phosphate-lowering therapies, into the bundled payment system. And while intended to streamline reimbursement, the move has instead exposed some very strong flaws in the overall bundled payment system. And we've been very focused on this in terms of the patient impacts. And we get our insights from patients and from clinicians in the field through our survey mechanisms. Earlier this year, AAKP conducted an independent survey through its Center for Patient Research and Education to find out how things were going. The results were rather troubling to us. Over 40% of dialysis patients indicated that they had experienced disruptions in their access to oral phosphate lowering medications. And we're quite concerned about this. But the other thing that was interesting in our survey is 75% of the physicians who responded indicate that they were having problems and barriers to getting access to the right therapy at the right time for their patients. And Dr. Williams, I want to come over to you and have you walk through the implications of this policy shift, just in terms of people and what you see, because I know you have a heart for patients and you know firsthand you've never become detached from direct care. Go right ahead.
Yeah, thanks, Paul. I want to also echo my gratitude for being on the panel. I really appreciate it. And you know, the statistics that you lay out here from the survey that you guys conducted, I think are really troubling. At the end of the day, what you like for any patient is to have shared decision making around the treatments and the care that they're receiving. And I think, you know, Dr. Shah just laid it out quite nicely. That shared decision making actually goes away in the setting where there is innovation, but not access. And so, from the standpoint of, you know, particularly the phosphate lowering agents going into the bundle, again, these are oral only therapies that are not actually related to renal dialysis itself. It's not part of a renal dialysis service. They should never even be there. But what it does, in a nutshell, is it just takes away innovation. I mean, we talked a lot about, sort of the innovation that happens from a preventive standpoint in this space, that we've had an explosion of that. And so when you look at, chronic kidney disease, and just look at the last, 10 years, only 10 drugs have actually been approved in the kidney space. That's tenfold fewer than oncology. And most of those drugs, 60% of them, 6 out of 10 of them, were, again, as Dr. Watnick said, in the pre-dialysis space. And I totally agree that preventive care is the right way to go. We want to look at ways to prevent people from getting to kidney failure. But as much as we do, there will still be patients who fall into that category. And what are we doing from an innovative process to make sure that we can make their lives better? I think phosphate lowering therapies is a potential opportunity to do so. When the kidneys fail, there's only two, sort of mechanisms to actually treat patients. It's either dialysis, maintenance dialysis, or it's transplant. And when we think about, phosphate lowering therapies, why is that important? Of all of the sort of, mineral abnormalities that happen once the kidneys fail, elevated phosphorus carries the greatest mortality or attributable risk to mortality. And so it's important, I think, for us to have every tool in our armamentarium to be able to manage that. And why is that important? Well, dialysis was never intended to be, a long-term solution. It was intended to be a bridge to transplant. And what we have seen, at least anecdotally, is that once we are able to actually control serum phosphorus, there are a number of patients who are actually become eligible for transplants, which is what you want. You're not only increasing survival rates by going through that path, but you're also decreasing costs to the system. So this, issue of putting these phosphate lowering therapies only magnifies the problem in terms of trying to actually get patients to where they need to be.
Thank you, Dr. Williams. One of the things that AAKP has focused on intensely in our congressional efforts and efforts before the executive branch, America is very committed to increasing opportunities for organ transplantation. But one of the issues that doesn't get talked about is transplant readiness, the ability of a patient to stay on the wait list or get waitlisted while managing other conditions. And I wanted to ask you a fast question here. On your experience in the patients that you work with, how big of an issue is this for transplant readiness for those people who are waiting for the opportunity to have a life-saving organ transplant?
Yeah, Paul, great question. I think it's a huge issue. And I think, while a normal serum phosphorus is not a formal criteria for a kidney transplant eligibility, that's often considered as part of a broader assessment for transplant readiness. Some people look at it from the standpoint of compliance and adherence, but quite frankly, we know that a lower serum phosphorus level at the time of transplant actually portends to a better graft survival rate. So transplant readiness and serum phosphorus are uniquely linked. And I think, again, having all of the tools in your toolbox to be able to manage serum phosphorus only gets patients closer to that goal. And certainly I have some anecdotal, sort of examples of that. But we need to actually look at data. We need to actually do research to show, again, that, you know, controlling one's serum phosphorus is a way to get more people to the transplant list. And isn't that what we want? Isn't that, what we're striving for? Again, preventive care is the best. But once a patient actually gets to kidney failure, we also then want to give them the best option for success. And so we understand that there are limitations in terms of the number of organs available, but that shouldn't stop us from making sure that we get patients as close to possible in terms of transplant readiness. And I think managing serum phosphorus is one of those things that actually gets us there.
Thank you very much, Dr. Williams. I think you put a laser on the fact that a government determinant of health, a payment system that's outdated, can actually negatively impact transplant readiness and overall kidney health. What I'd like to do now is go over to Liz Hurlburt from CorMedix. CorMedix has led in the field that a lot of people have talked about for a long time, and it's very serious for patients. And this is the issue of bloodstream infections, specifically catheter-related bloodstream infections for dialysis patients. These are devastating infections. And for over a decade, the federal government has had a coalition called Making Dialysis Safer through the CDC. Some of the brightest minds in America have talked about we need to bend the curve on infections that happen. Ed Hickey mentioned earlier today a CBS story that aired last Sunday, which we encourage folks to watch. But in terms of improving the opportunities for dialysis patients to stay healthy and to make certain they too maintain their transplant readiness is a very important thing. These infections cost people a tremendous amount personally. They can lose their life and they cost taxpayers a great deal. Liz, why don't you go ahead and break down what this issue is, what the therapy is that you folks have been able to bring forward in your experience working under a bundled payment system?
Absolutely. Thanks, Paul. And like everybody else, I'd really like to thank AAKP for having us here. And I echo a lot of what Dr. Williams and Dr. Shah had to say. And actually, Dr. Shah, I was in research for about the first 20 years of my career. And I think you brought a really excellent point up that if we are not able to get the products that we're researching to patients, it also disincentivizes research, right? And that's a really terrible thing. And similar to what Dr. Williams brought up when it came to the phosphate binders, our product is very similar in that it doesn't just relate to kidney patients. That's where we're indicated first, which I'll talk about. But it's a much larger issue. So thank you for having me today. And I want to thank AAKP. I have, over the years, had an opportunity to speak on kidney issues and affecting the community, and typically in many different facets, whether that be the patient experience, the provider challenges, industry innovations. But what I've really learned is that a hard truth. We cannot compartmentalize these conversations. Real progress in kidney care and healthcare demands a very collaborative and holistic approach, one where patients, providers, industry, and researchers all have a seat at the table. So I want to just step back for a moment to highlight a bit of an issue. So just imagine that you are being told that we as a society are facing a life-threatening problem, one that leads to serious hospitalizations, long-term complications for patients, and death 25% of the time. And that problem is preventable, right? So that alone should ignite grave concern and urgency and some immediate action to be taken. And that is exactly the case with catheter-related bloodstream infections, or CRBSIs. And CRBSIs are not new, they are not sexy or glamorous or a new technology or a new problem we are facing. But they are devastating to patients and to clinicians, and they are still happening. So I want to look at some facts and share some facts with you about CRBSI. So CRBSIs are among the most frequent, lethal, and costly complications in hemodialysis care. They carry a mortality rate of approximately 25%, and they disproportionately affect historically marginalized communities: Black patients, Hispanic patients, female patients with catheters. CMS spends over $3.4 billion every single year treating CRBSIs. And despite prevention efforts that are out there, a patient with a central venous catheter, or CVC, has a nearly 50% chance of developing a CRBSI in the first 90 days that it is placed. So I want to talk about that $3.4 billion, right? That amount of money, and this is annually, that amount of money could build 2 fully staffed 500-bed hospitals. $3.4 billion could get nearly 1 million Americans Medicaid. There are some incredibly important initiatives from a healthcare standpoint that we could do with those dollars. For many patients, catheter is their first access point for dialysis. It's often placed due to urgency or a lack of options or delays in care. And these catheters become life-threatening and life-sustaining simultaneously for patients, right? So just imagine that you're sitting in a dialysis chair 4 hours, 4 hours, 3 times a week with a device in your body that both preserves and threatens your life. And there is nothing you can do about it because you need it. I will say that dialysis nurses and techs do extraordinary work. They follow infection prevention protocols, they wear PPE, they use the core interventions, all of the things that are there. But the truth is, even with the best care, we cannot overcome the inherent risks of catheters alone. So, after decades without an approved drug to reduce CRBSIs, we now have DefenCath. It is the first FDA-approved antimicrobial catheter lock solution, and it's a combination of taurolidine, which is a broad-spectrum antimicrobial, and heparin, which keeps the catheters patent. So now the catheter could potentially be both patent and protected. And in our phase 3 landmark clinical trial, DefenCath showed a 71% reduction in CRBSI. So I want to pause on that. 71%, that is not an incremental improvement. That is a game changer for patients living with a catheter. And yet, patients are still walking out of clinics every day with their catheters locked with heparin or saline, offering no antimicrobial protection. And their lives depend on those lines. And too often, the lines are unprotected, right? And if you think about it, we don't drive without a seatbelt or an airbag now that we have them available. So why should our healthcare be any different? So similar to what Dr. Shah said, innovation means nothing without access. While we applaud the approval of DefenCath and celebrate that, the current reimbursement landscape is a roadblock. Temporary reimbursement models like TDAPA are well-intended but fall short. They're time-limited, they don't incentivize adoption, and they create financial disincentives that delay potential best practices from becoming standard of care. And what's more concerning is this: the post-TDAPA payment adjustment is applied equally across the board. So regardless of whether a facility uses an innovative product or not, they're going to get that money. And that's not equity, that's dilution. So it disincentivizes those who lead and inadvertently rewards those who delay. And for patients, it perpetuates a sense of a purgatory that is driven by reimbursement. We have to rethink what equitable truly means and equitable access, because fairness is not sameness. Equity means making sure that the patients that are most in need, those with catheters, those with a high risk, receive protection and not just promises. At CorMedix, we are committed to working with every stakeholder, including AAKP, to change this landscape. But the future of CRBSI prevention and innovative products doesn't rest on one company alone. It rests on all of us, and advocates, clinicians, policy leaders, and industry partners. And so I think it's time to stop slicing the problem into parts. It's time we stop accepting preventable infections as inevitable, and it's time we stop settling for incremental when the stakes are life and death. As someone who has worked in this field for nearly 2 decades, I've seen what change looks like, and it doesn't come by working in silos. It comes when we act together with clarity and courage and conviction. And I think we need to give patients more than temporary access. We need to give them protection. We need to give them dignity. And most of all, we need to give them what they've always deserved, a system that works just as hard for them as they do to live. Prevention isn't just possible, it's very long overdue.
Thank you very much, Liz. And let me just ask you this, as somebody who's involved in industry and has brought in innovation into the marketplace, you work very closely with patient advocates, not just AAKP, but a lot of different patients. And in your career, you've seen some of the impacts of these infections on people. What is it as a human being and as a person that you take away and that you bring to work every day based on your experiences that fuels your desire to try to make a difference? What are those things when you think back on the patients that you've known?
Yeah, I mean, I've had the privilege of taking care of patients and working with them for so long. And honestly, now when I hear that people are getting a CRBSI, the first thing I want to say is I'm sorry. And not me personally, but on behalf of the system, I'm sorry, because we could have done something better. And I think it's not because clinicians don't want to do better and nurses don't want to do better and industry doesn't want to do better, but the system that is in place does not allow them to. And that is not fair. And so I think for us, the fight is not over. I think, we will continue to innovate. We want to bring these therapies to patients to make sure that they have access. But it really is going to take a village, I think, to change this. And, I appreciate whenever patients share stories with us. I think in the beginning we heard from Charlotte, and when you put a face to the name and when you put a face to the story and somebody is in front of you and their life is on the line, how can you not feel so grateful to be part of that? And so I know that all of us at CorMedix feel very deeply that we are able to impact patients in such a positive way. And now all we're looking to do is scale that.
Okay, thank you very much.